welcome Dr. Goodkin.
Thank you, Susie. Okay, so I'm going to be talking to you about aging and neuropsychiatric issues in HIV. And while I have several relationships with pharmaceutical companies, none of them will apply to this talk. I will, however, be discussing off-label uses of medications for HIV-associated neurocognitive disorder or HAND, and that, in fact, is implicit because there are no FDA-approved treatments still specifically for HAND. I have to, I think, start off for all of you in giving you some background about HIV, HIV not being a psychiatric disorder. So I have a few slides to give you that background. And this is a slide of the virus itself. HIV is a retrovirus with RNA at its core. It has several enzymes that are critically important to its function, one of which is reverse transcriptase. And RT was the first enzyme that was inhibited to be used in treatment for HIV with AZT back in '87 when that was the first drug approved for the treatment of HIV. Protease became another target, and the protease inhibitors as a group became available in the end of '95, and with their advent, so came our ability to denote the combination antiretroviral therapy, or CART, as we now refer to it, as then was referred to as highly active antiretroviral therapy, or HART, but we don't use that term anymore because it's not exactly as highly active as we originally hoped. And it acts more toward the end of the virus's replicatory cycle. In addition, there are glycoproteins that HIV has, and particularly GP120 in the coding of the virus is neurotoxic and can induce neuronal apoptosis or programmed cell death. And HIV also has a regulatory protein called TAT, not depicted here, that is neurotoxic as well. And just to give you a sense a little bit about the progression of the disease from the laboratory surrogate marker perspective. The two major markers that are used in the lab to look at how patients are doing are the CD4 cell count, which drops early on, then stabilizes at a higher level for a number of years, out to 12 years without treatment, before it starts dropping off. And when it starts dropping off, there are categories of immunodeficiency associated with the cut points for CD4 cell count. So less than 500 cells per cubic millimeter is the first drop point where you get significant immune deficiency. The second is 200, and that's a very important cutoff because it later became AIDS defining, even without clinical definition of AIDS having been met. And the third that is used to predict mortality is a cut less than 50. Viral load increases early on after exposure, then stabilizes at a set point, usually at around 6 months, and then can be suppressed for long periods of time, actually, with the antiretrovirals now for an extended period of time if patients are adherent lifetime. But ultimately, with disease progression, will go up, and that will be in association with the occurrence of morbidity and ultimately mortality from the disease. So the life cycle of HIV, I'm not going to spend time actually walking you through the whole life cycle, but more from the point of view of familiarizing yourself with the drugs. As I mentioned, the RT inhibitors were the first group of drugs approved with zidovudine, now called AZT previously, and that inhibits the transcription of HIV RNA into a complementary DNA copy. Then we have at the other end of the replicatory cycle the protease inhibitors. First approved was sequinavir. And those actually prevent the clipping of pre-viral proteins in the final copies of viral proteins that are assembled into whole virions. We now also have the fusion entry inhibitors, and Maraviroc would be the principal one of these to point out. The drug Maraviroc inhibits CCR5, which is a chemokine co-receptor for the CD4 receptor that's on CD4 cells and monocytes that HIV uses to get into the cell. So it has to have the primary CD4 receptor as well as the chemokine co-receptor to enter, and Maraviroc blocks the CCR5 co-receptor. And then we have also more recently the integrase inhibitors that prevent the integration of the complementary DNA copy of HIV into our host cell genome. We don't actually have these drugs FDA approved yet, but they're in development, the maturation inhibitors. So in terms of aging in HIV, currently we have over 230,000 HIV positive individuals living in the US older than 50 years old. In 2010, the 50% threshold was crossed in San Francisco, and we're expecting that by the end of this year, it will be crossed nationally. How old is old? Well, a lot of you might be thinking, oh, Dr. Goodkin's talking about the elderly in this lecture, and that's not at all the case. In the days of tracking HIV by CDC, it was early decided that 50 years of age and older would be considered older compared to the rest of the population in the earlier stages of the epidemic. And so that became the general cutoff for older age in HIV, with most of the patients being in the 50 to 59-year-old age range, a minority being 60 to 65, and very few over 65. However, in the coming decade, we are going to see that number greatly advance, and I would suggest to you all that we're ill-prepared to deal with it. We have no studies about the true elderly in HIV. So this shows you the actual changes in percentage of people over 50 with HIV in the US. I actually started doing work in '99 before this graph started with an NIMH-funded project in the area. And you can see that it's significantly increased year after year, all the way up to now 2017, where we're looking at a 50% major marker for the cutoff of HIV being with 50% of people in the United States being over 50 years of age. That's an amazing statistic. Most people I talk to about HIV have no idea that that's characteristic of the demography currently of the epidemic in the US. Well, it's very important to understand, while there are so many people over 50 now with HIV, that they're not a homogeneous population at all. And in fact, there are three major subpopulations: the newly infected older patient. Those older patients tend to be highly stigmatized, isolated, passive in their health care. There's the newly tested older patient who's been infected for years but never diagnosed, and may only come to attention for diagnosis because of a complication of HIV. And then there is a relatively large group of long-term infected patients successfully aging with HIV and the positive impact of combination antiretroviral therapies, or CART. And those patients tend to be much more proactive in their health care, have good social support. They were typically diagnosed early, even without symptoms. So these are very different groups that you can think of as endophenotypes. What are medical issues for older persons newly infected by HIV? Well, a big one is that there's just a low index of suspicion out there that older people have HIV. Now, should that matter right now? The answer is no, because CDC recommends that everybody in the US should be tested for HIV at least once in their lifetime, regardless of risk. Just so you know that. We don't play the risk game anymore. But The problem is that that's still not the practice of many practitioners out there, and older people are generally the last people who are being suspected for having HIV. Older people don't have sex and don't use drugs, right? Why would you test them? Okay, so they're tested late after symptoms develop, which is very negative for the patient because at that point the impact of therapy is lessened. And something called a CD4 nadir gives us the data to prove that, because the CD4 nadir is the lowest point at which CD4 counts go in the history of treatment. And we know that even if you bring up CD4 cell to a normal level after treatment, if you have a nadir that's below 200, you're going to have significant immune deficiency persisting despite treatment, and below 100 even more, and an increased likelihood of hand. So there's a decreased survival time for the older patient. Now, is this lead time diagnostic bias was an early question, and data showed, in fact, that this did not appear to be the case, and you can see older patients dropping off here in survival time compared to younger patients studied by Cassot and Hopkins in 2005. So what about the setting of response to treatment for the older patient? How do they do? Well, one interesting thing is that they typically do better in terms of adherence or are not different than youngers, except when they have cognitive impairment, which you wouldn't be surprised by, and then they do worse, and that's very important in terms of why we're so interested in hand. Not just to treat hand, but also to prevent disease progression generally. They have a similar virologic response, a slower immune response to therapy, more frequent toxicities, more frequent medical comorbidities and psychiatric comorbidities, and overall clinical disease progression. So older age is highly predictive of mortality. And this was true prior to the combination antiretroviral therapies being available, but it's also true after their availability. And it's been shown even adjusting for normal aging. So there's a spectrum now focusing more on HIV-associated neurocognitive disorders specifically of severity of these disorders that I want to share with you. And the worst, as I think you all would be aware, is HIV-associated dementia, formerly AIDS dementia complex in the old days. Then we have HIV-associated minor cognitive motor disorder, which we now refer to as mild neurocognitive disorder. Subclinical HIV-associated neuropsychological impairment, also referred to as ANI, asymptomatic neurocognitive impairment, but I think subclinical is actually the better term. And then there's no neuropsychological impairment, but the potential for neuroprotection. So I'm showing you here a very old slide that comes from the mid-'80s. I saw my first HIV-infected patient, I should say, in '83. And this slide was used to depict the disease progression systemically of HIV, with AIDS at the tip of the iceberg, then non-AIDS defining OIs, opportunistic infections, and constitutional symptoms just below that, and at the base, asymptomatic HIV infection. Well, the spectrum of hand is very similar to this iceberg, with dementia at the tip of the iceberg, mild neurocognitive disorder below that, subclinical cognitive impairment, and then no neurocognitive impairment at the base. I was involved with the Frascati conference, in which the nosology for these disorders was changed, and we ended up having these three terms. Mild neurocognitive disorder was different, not just because it was renamed from MCMD, but MCMD was a symptom-based diagnosis, and MND was neuropsychologically testing-based, just like HAD, which was very important. And ANI was introduced as a diagnosis at that time, and that was in 2007. Now, this slide shows you something else that's important too. If you look at the left as neurocognitive impairment, and you look at the right as functional status, you'll see that In terms of neurocognitive impairment, HAD is the larger rectangle compared to the other two, which are equal, because you have to have more severe impairment at a level of 2 domains with 2 SDs below the mean, whereas the other two are 1 SD below the mean for at least 2 domains. And functional status is a little different because what you have is you have a coning down across the 3 conditions. And for dementia, you have to have at least moderate to severe functional status impairment, mild functional status for MND, and no functional impairment for asymptomatic neurocognitive impairment. Well, let's talk a little bit about the interaction of HIV infection in older persons with hand and with mortality. So from the start, what we can do is look at the overlap of older age and HIV with hand, and you can see that that's a large overlap, over 50%, which is what it would be without the consideration of older age if you just looked at hand prevalence in general in HIV-positive individuals. Here you can see that, as expected, there's an overlap of older age with mortality in HIV, and there's an overlap over here in hand in younger individuals with mortality, but much larger is the overlap of older age and hand together with mortality. And that's become a major area of research interest. The increased risk for mortality in hand has been shown across the levels of cognitive motor disorder progression, with the worst being HAD, as you all know, and very clear evidence of an association for mortality with HAD going back to the early 90s and Justin MacArthur's work in Hopkins. Risk of MCMD, now referred to as MND, for mortality of 2.2. Ron Ellis and UCSD colleagues showed that. And we did some work in the late 90s as well looking at asymptomatic neurocognitive impairment and showed that specifically for cognitive domains of information processing speed and verbal memory, there was an increased risk for mortality even at that level. So older age and hand risk is something that we want to discuss as well beyond the associations with mortality. And so we're going to look at the 3 levels of HAD, MND, and NCI in general. And there is data also going back to the early 90s showing the association of age with HAD in this study by Justin MacArthur. Also an epidemiological study in Europe that showed the association of age and HAD, and a study in the CART era that was well controlled showing that it persisted into the current era. I was funded actually by the NIMH to look at earlier stages, and so we did a 2-by-2 design looking at older and younger HIV positive and negative individuals in a study with English speakers and simultaneously a study with Spanish speakers. And in the study with English speakers, we found that you could look at the association of aging and MCMD symptoms and see the expected association of higher levels of MCMD symptoms in older positive individuals compared to younger positive individuals. And interestingly, younger positive individuals had a similar level of MCMD symptoms to older negative individuals, showing that these symptoms are not specific to HIV. They can occur with aging as well as HIV, and we were one of the first to show that, which we published in 2001. Older age and neurocognitive impairment generally across the levels of systemic disease progression has been studied in many studies as a separate issue from disorder. And there have been problems with interpreting the studies because there have been variable effects. And that goes from looking at the effect of older age itself, although that was mostly consistent with showing effects that were negative with neurocognitive impairment. Less consistent was the effect of HIV serostatus itself on neurocognitive impairment. And of great interest was that there were few significant interactions between aging and HIV on cognitive impairment. And in fact, Sazik, in 2011, an Australian researcher suggested that this was not even a major source of further research because it appeared that the effects of aging and HIV were independent and additive, but not truly synergistic. We were interested specifically in working memory, and so we looked at my study at 99 older seropositive adults with the digit span backwards test, which is what you can think of as a poor man's working memory test. And we looked at the relationship of deficits in working memory with the other domains that we tested. So we divided participants into two groups, impaired and non-impaired working memory, and we found, you can see in the red, the impaired working memory group had significant relationships with impairment in all of the other domains tested, including episodic memory and global function as well. So we suggested that working memory deficits might be a gateway to the expansion of neurocognitive impairment into other domains and ultimately to disorder. In terms of looking at age and risk for hand, then we can summarize by saying that the strongest relationships are with dementia, next strongest relationships with mild neurocognitive disorder, and least strong relationships with neurocognitive performance overall, not disorder per se. An important issue in interpreting these studies is variation of control variables that was a concern in how much you could feel like you really were looking at the effect of aging. So extrinsic factors influencing hand are very important to consider. And we know that comorbidities are generally associated with decreased functional status and survival time in HIV. And specifically for cognitive impairment, we're obviously concerned about diabetes and hypertension. In terms of mortality, arthritis, distal sensory polyneuropathy, peripheral neuropathy also is a concern, both being associated with falls and then with mortality. And we also know that with increased concomitant medication use, there's increased drug interactions and decreased adherence with progression of the disease related to that. But what about psychiatric comorbidities? Well, we have a major concern for major depressive disorder in the HIV-positive population. And in fact, to this date, major depressive disorder is under-recognized and undertreated in HIV. One of the reasons being is that people frequently say, well, the HIV-positive patient is stressed, so you can understand why they're depressed. Or another reason is, well, they have all these other medical symptoms. I'm not really sure they have major depression. And this is different from looking at depressed mood level and anxious mood level, of which there are numerous studies that many times are generalized to disorders which shouldn't be. And we also need to be looking at the impact of alcohol and substance use comorbidities, very important vis-a-vis cognitive impairment, as I'm sure you would all appreciate, but unfortunately is not always done. In terms of neuroanatomy, there's a converging focus on the hippocampus, not only because HIV itself has a predilection for hippocampus in early CNS infection, but also because older age affects hippocampus and is associated with atrophy of hippocampus. So is major depression as well as chronic stress. So you can imagine all four of these converging and creating a synergy that relates to hippocampal atrophy and implications, therefore, for HIV-associated neurocognitive disorder. Well, it doesn't end there in terms of the complications involved, because the HIV medications themselves can cause neurocognitive impairment. And the one that's most notorious for this is efavirenz, trade name Sestiva, with greater than 50% CNS side effects, and you can see some of them here in a study that I was involved with, ACTG 5097S. There we thought that the side effects were actually relatively short-lived, and it's true that patients can be treated through them, but it turns out subsequent studies have shown longer follow-up, you still see these side effects. Interferon alpha treatment for concomitant HCV infection, hepatitis C infection, is no longer as big of a concern as it was neurocognitively because, fortunately, these days we've progressed beyond using interferon and ribavirin to using direct-acting antivirals for HCV that don't have these cognitive effects. And in fact, we can cure HCV at a 90% rate. Now, of course, we can't cure HIV at all. Reason being, HIV becomes latent in our genes and in our host cell genome, and therefore, is always there, no matter what you might try to do in terms of controlling it. Another complication of looking at neurocognitive disorder in HIV is a syndrome called lipodystrophy syndrome, which is associated particularly with the protease inhibitor class, but also with the nucleoside RT inhibitors, and it is also related to mitochondrial toxicity. Here you see a patient with lipodystrophy syndrome, and you can see the facial lipoatrophy, breast enlargement, central adiposity, was originally called Crick's belly after Indinavir Crixivan, and peripheral lipoatrophy. And this syndrome is associated, as I suggested, with mitochondrial toxicity and adipocytes. So these are your mitochondria normally, and these are your mitochondria on antiretrovirals. The process begins as well physiologically that's associated with lipodystrophy syndrome in insulin resistance. And so we avoid now PIs that are associated with insulin resistance. We switch away from their use. And we actively screen, importantly for the older person with HIV, for insulin resistance as being the first step in the pathway of toxicity that goes on to glucose intolerance and frank diabetes. That older persons are at risk for anyway independently, and with the use of the antiretrovirals, especially the PIs, more so. Psychiatric disorder is relevant here because there's increased comorbidity of diabetes with affective disorders, particularly major depression, and the SSRIs actually decrease glucose levels and insulin resistance. We typically try to avoid antipsychotics, especially the atypicals in this regard, and if we do use them, we prefer using ziprasidone and aripiprazole. Here you can see, looking now at the clinical implications of lipodystrophy syndrome and dyslipidemia, the impact in terms of looking at clinical events of myocardial infarction in HIV. And this study, the DAD study published in the New England Journal in 2003, shows you that there is actually a linear association with exposure to combination antiretroviral therapy. Why is that relevant in this discussion of hand? Well, if you have coronary artery disease risk, you can pretty well expect that you will be affecting the cerebrovascular tree as well, and that's exactly what research subsequently showed when CVA risk was looked at. And this study by Evers looked actually at incidence of a stroke with older age and showed that the associations were similar in stroke as what occurred in MI in actual incidence. Now, preceding these studies, there were studies showing using transcranial Doppler studies that you could look at cerebral vasomotor reactivity and find these associations with aging. And you could also look at carotid intima media thickness and see these associations. It's actually a stage of studies that goes through CVA at the end point. And it's also the case that we not only have macrovascular disease to worry about, CVA and HIV, but microvascular disease as well, and that relates to hand risk. And a study by Valcor and colleagues looked very definitively with multiple controls for other factors to show the association of diabetes with HAD was quite strong, 5+ in odds ratio. These days, we're very concerned about trying to make sure that we're excluding other causes of cognitive impairment when we're looking at the impact of aging. And so here you see a number of them listed. And we talked about prescribed meds, the ARVs themselves, substance use toxicities, systemic illness, CNS infection, tumors, obviously, traumatic brain injury, depressive disorders, and non-HIV associated neurologic disorders. Confounding conditions are more frequently a concern with older age than in younger HIV-positive individuals. And we know that the comorbidities in aging merge with the complications of HIV themselves, suggesting that the synergism at the clinical level takes place. We also try to very explicitly rule out confounds with these new Frascati criteria, so we can look at confounding conditions versus contributory conditions. And aging is now generally considered a contributory condition toward hand. Another factor in looking at the complexity of this is that when you have hepatitis C virus co-infection, you have to really control for that. Hepatitis C virus can affect cognitive impairment, can cause cognitive impairment without HIV and without metabolic effects. And it's relatively common in the HIV-infected population that you see HCV co-infection with 25 to 30% co-infected. And HIV infection accelerates the progression of HCV to cirrhosis, hepatocellular carcinoma, and mortality. There's also a risk in the co-infection for hyperglycemia and diabetes related to hand. So let's talk about the treatment of hand in the older patient. Very interestingly, I think, for many of you, things have changed quite a bit from the old days with multiple medications being used many times a day in the treatment of HIV with the antiretrovirals. We've reduced the pill burden very significantly. We have one pill once a day regimens now, like Stribild. And we also have in development long-acting antiretrovirals, and I think this will be really important, especially for a population of major concern to me in psychiatry, the severely mentally ill, who, if many of you don't know, are at higher risk for HIV, as well as HCV infection. And we'd like to get them treated with long-acting injectable antipsychotics more frequently on discharge rather than orals, and for the HIV infected subgroup of those patients, maybe we'll also be starting them on long-acting antiretrovirals in the not-distant future. Well, what's the approach to using the antiretrovirals themselves to treat hand? And the main group of interest is in the middle, and this is when you diagnose hand in patients already being treated with CART. What we do is we switch or intensify the regimen. So switching means to drop one drug that's not very neuroeffective, doesn't penetrate well into brain, and to put in a drug that has better penetration, and intensification means adding a drug. Well, we also have the situation where we might diagnose hand and there's no CART being used, and right now that would mean that the patient is not known to be HIV positive, because for all HIV positive patients now, antiretrovirals are recommended, not once you achieve a cutoff of CD4 count, but at any time HIV is diagnosed. And so these patients may be coming to psychiatrists with neurocognitive impairment and only HIV risk. And so it's incumbent on psychiatrists to look at what they're doing as including examining HIV risk and testing for HIV in a situation where there's neurocognitive impairment as the chief complaint of the patient. And what we do in this situation is we start antiretroviral therapy that is neuroeffective. What about when we have no hand and we're treating with CART? That is, what about neuroprotection in the HIV positive identified patient? We don't really know that much about it right now. We don't have data on it. And right now, the recommended regimens are not actually covering for that possibility, that the initiating regimen should already cover the CNS. This is something that might evolve over time in the near future. Here you see how we look at this quantitatively. So when we're seeing a patient with hand, what we'll do is we will use these rankings of CNS penetration effectiveness developed by Scott Latender and colleagues at UCSD, and we will add the ranks of different drugs. For example, raltegravir being a 3 with emtricitabine being a 3, and tenofovir being a 1 gives you 7. 7 is the actual average of CART regimens for CNS penetration. If we're trying to improve it to get a cognitive effect, we're trying to get 3 more points to a 10. A couple of the newer drugs are of great interest vis-a-vis cognitive impairment, one of which is moraviroc that I discussed briefly at the beginning, the CCR5 co-receptor antagonist. CCR5 is very important in hand because CCR5 is the co-receptor on monocytes that carry HIV past an intact blood-brain barrier into brain early on in infection, and is thought to guide the progression of infection long-term in brain. So moraviroc has been looked at in studies as an add-on with antiretroviral backbone regimens with nucleoside RT inhibitors and has been shown to be effective in improving cognition. And also in the integrase inhibitor class, where we're looking at trying to prevent latency, raltegravir has been looked at positively with effects on neurocognitive disorder, and newer drugs in this class are currently being looked at, elvitegravir and dolutegravir. So what are the implications of this clinically? Let's go back to the clinician here. Let's go back to the clinician who's a psychiatrist. Why are we talking about all this to a group of psychiatrists? A major reason we're doing it is that when I talk to ID primary care providers, they're not necessarily thinking about CNS penetration as a way to look at hand. And in fact, they typically don't diagnose earlier levels of hand. And we're needing to try to get them more active about doing that. And relationship to that, it's not like they used to think, well, they were nihilistic about it. We can't do anything about hand anyway, so why should you try to diagnose it early? Is that going to help anything? Well, we think there's evidence to suggest that their own antiretrovirals help, and we need them to collaborate with us if we're going to make that argument because they're prescribing the antiretrovirals. And it may not always be as simple as looking at that ranking that I showed you, because you have to look at the resistance of the patient to the antiretrovirals, and the resistance profile may be such that the drugs that you'd like to add, you can't add because they're already resistant to them. So it really takes collaboration to make this plan work, to use the antiretrovirals effectively. However, when that doesn't work or the communications don't work, we still have things we can do in psychiatry to treat the patient with hand. And the primary focus for that, in terms of data suggesting that we have good efficacy at least, are the psychostimulants. And they have good evidence for hand efficacy, but in a relatively shorter term. We need to watch for side effects, as you would expect, particularly in older patients. But we usually don't find that abuse is a problem, especially in the older patient. Most commonly, you'll see studies starting out with methylphenidate and then using dextroamphetamine as a backup. And then not studied well, but is switching to longer-acting preparations and possibly using in combination with shorter-acting to achieve maximum control of symptoms. I like to reserve this and try using lower levels of stimulating medications like atomoxetine and modafinil, and even a stage below that, I would say, bupropion and venlafaxine. So I gear up to the controlled substances if I really have to use them. Of course, in late dementia, which you don't see that much anymore, if patients have psychotic symptoms, we don't want to maintain the psychostimulants. What about looking at aging, HIV, and comorbidities related to treatment now in a bigger picture, beyond looking at hand, but including looking at hand? We know that with increased comorbidities, we have an increased potential for drug interactions. Drug interactions are major in HIV, and they're very important in psychiatry because the antidepressants and the benzodiazepines are both involved in terms of interactions, particularly with the protease inhibitor class. And older HIV patients are more prone to interactions. They have decreased renal clearance, decreased hepatic clearance, and decreased albumin and drug-binding proteins. We're also concerned, as I alluded to earlier, about peripheral neuropathy. And peripheral neuropathy is relatively common. It's more common in older HIV-infected patients, just like hand is. And in fact, there's an association of peripheral neuropathy with hand, which we think relates to the mechanism being inflammatory. It's very important to identify peripheral neuropathy and treat the pain associated with the peripheral neuropathy because it not only affects the patient's functioning, but also their adherence to the antiretrovirals and their systemic disease control. Lamotrigine has been effective, pregabalin as well. So we think that continued aging is more likely going forward to increase the diagnoses of ANI and MND, going back to our hand-specific picture, than HAD. What the antiretroviral combinations really did was they dampened the severity of neurocognitive disorder. So we don't see dementia like we did in the old days, but what we do see is more ANI and MND. And overall, we have the same prevalence of hand that we used to in the old days, which is why this is ongoing. It's such a major concern. So we don't think dementia rates are likely to increase. And in the coming decade, when we see more people over 65, we're going to find out exactly whether our predictions are going to be holding true or not. So right now, we have this 50% prevalence across levels of hand in patients stable on combination ART. And we know that we want to identify neurocognitive impairment. All levels of impairment predict mortality, and cognition, of course, is critical to a person's functional status and adherence. So this means we really need to screen actively for hand, and particularly older patients. So how do we screen for hand? Well, here's a number of screening instruments that have been recommended, mini-mental being the weakest of all because it's more cortically focused, and HIV neurocognitive impairment is related more to subcortical changes. The HIV dementia scale, international HIV dementia scale can be used, exit interview, and more neurologically exam-based, and MoCA. MoCA, the Montreal cognitive assessment, was thought to be the answer, actually, because it was going to be a mix of cortical and subcortical tests that would be good, but turns out that it hasn't turned out to be that specifically useful for hand, although it is very useful for minor cognitive impairment in the general population. So the current thoughts on hand screening are that there are no clear-cut data for any single screening instrument, which is unfortunate because you have to go to then neurocognitive testing more. So what we're looking at is, what if you select like one neurocognitive test with screening tests? Does that really help increase the ability to pick up cognitive impairment in HIV? And Trails making test A, for example, is one that's been looked at in this regard. But suffice it to say that neurocognitive screening is weak. Well, let's talk now about treatment again. And I'm going to expand beyond what we've discussed already with regard to the antiretrovirals and the psychostimulants to talk about other treatments for hand. Now, these other treatments for hand, let me start out by saying, have much less data to support them. So they are less frequently used, and they're more frequently used by hand specialists in conjunction with advising the patient that we're using an off-label drug. In some of these cases, there's actually only drugs under study to advance an argument for them. A major focus, though, of these groups of agents is inhibiting the CNS inflammatory response. And we know now, by the way, that even when we suppress viral load to non-detectable levels with combination antiretroviral therapy in the plasma, we are not doing the whole job on progression of HIV because the inflammation continues due to HIV, regardless of shutting down viral replication, and it's associated with morbidity and still earlier mortality. And markers of inflammation that are used for this are highly sensitive C-reactive protein, IL-6, and D-dimer. So we still are up against it, if you will, even with good control of virus replication to block down the inflammatory response, and specifically in the CNS for hand. TNF-alpha is a pro-inflammatory cytokine that is associated with hand and also with upregulation of HIV replication. We can use drugs, for example, that have been used in rheumatoid arthritis, like etanercept, infliximab. IL-1 is another pro-inflammatory cytokine, likewise, that can be blocked. IDO inhibitors are of special interest now, and they're really of interest to us in psychiatry too, because IDO inhibitors not only block the production of quinolinic acid and inflammation from that route in terms of tryptophan catabolism, but IDO inhibitors make that tryptophan pool therefore more available for anabolism or synthesis of serotonin, and therefore lowering the likelihood of major depression. And so major depression and inflammation are connected along with HIV-related inflammation that we think is the underlying cause of the synergism that can occur with major depression, just like we think that there's a synergism occurring with aging and inflammatory products. Minocycline was thought to be, however, a potentially effective agent, was tried by the ACTG and not found to be effective. Calcium channel blockers were thought to be potentially effective. Nimodipine was tried by the ACTG 362, was not effective. Antioxidant results have been very disappointing also. The studies of these agents currently haven't really shown much to support them, but we need to continue them. In terms of neurotransmitter manipulation, more related to psychiatry again, you would expect, for example, that memantine would have been an effective drug looking at glutamatergic transmission, which we know is important in HIV neurotoxicity, but ACTG 301 did not show memantine to be effective in hand. So you really have to do the studies, not just think of the mechanisms. Restoring dopaminergic transmission is important because CNS dopamine decreases with HIV disease progression centrally. That's known, so a DA agonist may be useful, haven't yet been studied, like pramipexole and ropinirole. Selegiline was studied in ACTG 5190, not found to be effective for hand. Interestingly, a recent study by Ned Sachter and colleagues at Hopkins showed an effect of paroxetine for the SSRIs. And the question is this related to enhancement of serotonergic transmission, which is also depleted with HIV CNS infection, or is it an anti-inflammatory effect? A lot of people ask me, Dr. Goodkin, why are you talking about all of these other neurotransmitters when you can just use the acetylcholinesterase inhibitors? Well, you can't really in HIV because acetylcholine is not depleted with CNS HIV infection. Dopamine and serotonin are. The antipsychotic medications I mentioned, we really try to avoid at all costs if we possibly can, and we use ziprasidone and aripiprazole when we have to. due to the side effects of the typical drugs, clearly have side effects of concern, both high and low potency, and then the metabolic syndrome for the atypicals. Other hand treatments in development, I'm not going to spend much time on this except to say lithium and valproate are GSK3 beta inhibitors, which have been studied with mixed results thus far. Neurotrophic factors need to be studied more. Particularly, aging and hand mechanisms of importance for convergence are quinolinic acid that I mentioned as a tryptophan catabolite, dopamine loss, where both aging and hand are impacting on loss of dopamine, and Parkinsonian symptoms, actually, you can see with HIV. And interestingly, increases in amyloid beta related to TAT, and that HIV regulatory protein I mentioned, inhibiting neprilysin. And oxidative stress is another area of convergence between aging and HIV, reactive oxidative species and focus there, especially in hippocampus. Well, coming close to the end here, I want to share with you a study that is currently approved pending revision in Lancet HIV that I've conducted using the MAX cohort that started in the mid-'80s with a group of colleagues from places around the country, Eric Miller at UCLA, a neuropsychologist, David Ostrow, a neuropsychiatrist, Eileen Martin in Chicago, neuropsychologist, Ned Sachter of Hopkins, I've already mentioned to you, Jim Becker, Ned's a neurologist, Jim Becker's a neuropsychologist in Pittsburgh. We looked at, in this study, a total of 5,000 plus participants and over 47,000 max visits. And we had 20,000 plus max visits for HIV positive individuals and 27,000 plus for HIV negative individuals. So this is a big data study. We looked at age as a continuous variable, HIV clinical disease stage, including serostatus negative with the 3 stages within HIV positive, and very much of interest to us in our predictions, the age by HIV stage interaction. We had multiple exclusion criteria and covariates that you can see here that we were able to apply with statistical power because we had such a large sample size. And statistical analyses were carried out by linear mixed models. And to summarize, for those hypothesized interactions for the synergism of aging and HIV, meaning that the aging and HIV effect was worse than just the individual effects, we found that there were deleterious effects for 2 domains, episodic memory and motor function. But we only found this, very interestingly, after we added a control for HIV serostatus duration as a marker of length of infection. And we think this is very important for future studies to try to look at this more carefully. In terms of motor function, the neuroanatomical referent we felt was appropriate here was the basal ganglia, which are known to be impacted early in HIV brain infection. I mentioned Parkinsonism associated with hand. For episodic memory, the neuroanatomical referent, the hippocampus, which I've already focused on quite a bit with you in this discussion. There are a number of correlative neuroimaging studies that support this synergism at the level of basal ganglia and hippocampus, including longitudinal studies out to 8 years, and a recent study suggesting that maybe another domain, if you will, beyond looking at episodic memory and motor function might be considered to be increased attentional load or burden. Major depression also comes into the picture again, folks. So again, bringing us in terms of primary psychiatry back into this area of very specific HIV psychiatry, you might say. Major depression has recently been found in the Charter study, which is a multi-site longitudinal study of HIV positive individuals started in the CART era in the year 2000, to be associated with CSF HIV RNA load. And so you can see here that those with a higher CSF viral load had an increased likelihood of episodes subsequently of major depression. and that risk factor was nearly 5. And Hammond, who did this work, also did controlled analyses looking at this relationship. And model 1 was controls for looking at plasma RNA simultaneously and adherence, and model 2 had multiple additional controls, and you can see, if anything, the relationship gets stronger. So where is hand treatment heading in the future after all of this? One of the major reservoirs for HIV is the brain. And why is that important? Well, these days, we are able, as I mentioned, to suppress viral load in the peripheral blood to non-detectable levels, less than 20 by the typical assay. However, we know that there are a number of reservoirs in the body that are not affected, even when we're suppressing that viral load in the blood. One of them is the brain. And so we're very concerned about this. And ultimately, the move now in therapy development, primarily in HIV, in primary care, now I'm saying, is to eliminate virus from reservoirs, rather than just suppress virus to non-detectable levels in the blood. And the rationale is this is going to get us closer to what we might consider a cure to be. Now remember, I said we can't really cure HIV because it becomes latent in our cells. So the best we can do is get what we would call a functional cure. But of course, when you're going for the best you can, a functional cure, will be good if we can't actually eradicate truly HIV, which we can't do. And there's already been a few cases suggested where a functional cure might have occurred. One infant that was treated subsequently, however, after discontinuation of antiretrovirals later down the line, actually did show HIV replication, so that wasn't permanent. So what we're now doing is developing what we call kick and kill strategies, where we flush out, quote unquote, the latent HIV from its reservoirs, including the brain, using HDAC inhibitors as latency reversing agents to induce HIV gene expression. And in the setting of treatment with CART, we're killing off those cells infected by that emerging virus. So we're actually increasing the replication of HIV to kill it off in reservoirs. You can imagine this is somewhat concerning to people because you want to make sure that things don't go the wrong direction when you do something like that. Very unfortunately, though, I think what the research on LRAs is already showing, and I was just at the ACTG scientific network meeting in February on this, is that the HDAC inhibitors are not actually as effective as we thought for doing this latency reversal anyway, and we may need to use combinations of them and other drugs. And one investigator said it's not kick and kill, it's pick and hope. And I'll just end with a resource that's an Aging and HIV Consensus panel that was part of the American Academy of HIV Medicine's efforts to look at this clinically. I was a part of this panel. I strongly recommend it for anyone interested in clinical care of these patients, and I'll close. And I know we're at the end of our time, but if there are any questions, I'd be happy to take them. Dr. Ordway.
Very outstanding presentation. I just was curious about concern that there may be about using amphetamines to treat cognitive problems in a disorder, that the last thing you think you'd want to do is raise the risk of even more reactive oxygen in the brain. Because stimulants like amphetamines are known to increase oxidative stress. You can kill hippocampal neurons, for example, in high doses.
Right. So the question is about that there may be a toxicity of the amphetamines related to increasing inflammation in using them, and that may very well be the case. Remember, I mentioned that there are no long-term studies of the psychostimulants, and that might be something that would be very well, found in long-term use that needs to be looked at. And I actually tried to get such a long-term study funded without success because It was a controlled drug, and we don't really know if we want to give it really long-term in these patients who are susceptible to substance use anyway. And so I wasn't able to convince even the ACTG that's so interested in this to do that. But it really needs to be done, and that's a great example of why. Dr. Chandrea.
You mentioned that the Benson studies using Sotera and Etexa, I think you said, as far as agents. Is that
Yes.
right? So I was wondering, you talked about peripheral neuropathy also, so has there been any studies of Cymbalta possibly to cover kind of two areas?
No studies of Cymbalta with cognitive impairment in HIV, and I think that's an interesting, idea to try to look at that, look at the pain and cognitive, impairment together. Something that would be very good to look at. Yes, John.
When the AIDS epidemic first came out, a very high percentage of AIDS-defining disorders were mental or neurocognitive.
Right.
What percentage, in the current era, what percentage of HIV-positive patients present with neurocognitive problems?
Well, the number, that's a great question. The question is now, if you see neurocognitive impairment and you find that the patient has HIV, how likely is that as the initial presentation? It used to be estimated that percentage was 10%, but that goes back to the early days of effective CARD, but back some time. So these days, I would say there's not a clear-cut answer. It hasn't been well studied further than that. So I don't think I could give you an answer for what that number is right now. But that's what it was felt to be. As ongoing, that even though we don't have data, because those data came out of the early CARD era. So I think that we have to have our antennae high for testing for HIV, because we don't really know that. And we do know that if we have neurocognitive impairment, we can't only assume that HIV risk factors should guide us in making this decision. And we certainly shouldn't assume that if it's an older patient, that's a reason not to test the patient. So I use this as part that it can present with neurocognitive impairment to a psychiatrist as a reason that psychiatrists should own doing HIV antibody testing. Still, even though, but the current data are lacking.
Do you have a feeling? I won't hold it.
Yeah, I think that it might actually be less than it was, and that has to do with the idea that what's happening now more in HIV is there's transmission going on with less virulent strains related to the impact of therapy at a community level, and therefore with less virulent strains being more common, maybe neurocognitive impairment is not as common presenting. That's just a hypothesis.
A lot of what you presented might fit with an idea that HIV affects neural stem cells. To study that, what's the progress in rodent models for HIV infection?
So what's the progress in rodent models for HIV infection, and specifically for hand? There's been a number of different models that have been studied. Howie Gendelman at the University of Nebraska, Omaha, has been one of the longer-term researchers in this area, and they have actually injected HIV into brain of neonatal rodents and then looked at what disease progression was like comparatively, and found that was one model that worked. There are SHIV models, a combination of simian and human HIV that have been used. Janice Clements has used a model like that to try to get cognitive impairment more quickly and be able to examine it with relationship to the systemic disease progress that way, and intervene in animals in a way that we couldn't do in humans, to look at, where in the body are these, levels of progression occurring that lead to brain infection. One of the interesting things that's coming out of that work is that, unlike what was earlier thought, HIV gets into gut-associated lymphoid tissue very early, and it appears that that is relevant to activation in brain of HIV-infected cells, and that activation ultimately may be related to hand development. Hypothesis at the moment, but something of relevance to that. Thank you, folks.
What to go?
For some reason, it didn't seem to come on until after I started that mic.
Huh.
Not sure why.
Maybe it wasn't loud?
Maybe I wasn't activating it quite enough with the volume.
Maybe it was the volume, because I could monitor you from the back, and while you were sitting here, it was low, but I could still hear the noise.
Yeah, we didn't want it to be overpowering, but I think at the beginning there, I might not have even been activating it, so it might have sounded just like it was talking without any kind of amplification.
Could be.
But as it went on, within the first 5 minutes or so, I think I picked up a little volume.
Okay.
I imagine for the broadcast, it doesn't matter, right? Because you're
Yeah, I got my own mic. Yeah. These aren't the best either. What do you do?
Well, I thought it went very well, and I
Yeah,
appreciate
I
the
agree.
support very much.
Oh, you're very